Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone. Since it's already 9:37 like that, so I think we should just proceed. Because I'm not sure how many will turns up. Sorry? Are you talking just now, Mr.?
Sorry, I'm talking to my son.
Oh, I see. Okay. So this is basically today's tentative. So we have done with our first part, which is basically on the basics of the treatment planning and the 3D with a few beams. And then today we are going to focus more towards a complex treatment planning, which is involve IMRT, VMAT, and also after that, Mr. You are going to touch a bit on the patient-specific Q&A. Sorry, QA. So this is the tentative for today. Hopefully we can just follow this, or since we are going to start late, so we are expecting that we are also going to have some delay with the program. Hopefully you are ready for today. And just like before as well, so I hope that you can interact with Miss Teo, can answer her question. And if you don't understand, so please just ask a question, okay? So without further ado, so I'll pass to Miss Teo.
Give me 2 minutes, I'm going to take my pen.
Sure, sure.
Okay, good morning, everyone. So let's share my screen. Okay, can I start now?
Yes, yes.
Okay, so today our topic mainly is IMRT patient QA. So, okay, what is IMRT? Everyone know what is IMRT, yeah? This one is teach in the school already, right? So
Yes, yes.
I just refresh brief teaching lah. So IMRT stands for intensity modulated radiation therapy. Means we modulate the intensity of the plan of the Remap. So it is advanced from the.
Miss Teo, sorry, can you just make it into a slideshow?
Oh,
So that
sorry.
it's a bit bigger.
Okay, it's an advanced form of conformal radiation therapy. Conformal radiation therapy means the previous class, our 3D planning technique. Then what is the advance from IMRT compared to 3D? So we can improve the dose delivered to the tumor while we reduce the dose to the healthy tissue. Okay, so by using IMRT, it creates a better treatment with a better outcomes. So the life expectation and the quality of life will be better for patients because we have reduced a lot those to the healthy tissues. So with the better treatments also is very less side effects. So and here you will see here a much less burden on healthcare system. This is meaning by if everyone is treating 3D compared to everyone is treating IMRT. So if everyone is treating 3D conformal therapy, means they may encounter a lot of side effects, which if you have a lot of side effects, you will have to see maybe, for example, for head and neck cases, you need to see dietitian, you need to see the ENT doctors. So you may need to go to see a lot of disciplinary of doctors, and then you need to get more medication to reduce your side effects. So means this is why they said if we use IMRT with less side effects, so we will less burden to the healthcare system, because by using IMRT, lesser side effect means you no need to see dietitian, you no need to see the no need to see the ENT doctors, and less using the medications. So, and also there's a less repeat patients, means if we are using 3D patient, 3D techniques, there is part of tumor we may miss to treat it, because the dose to the tumor may also not as enough. The dose to the tumor may not enough to kill the tumor cells. So if we are using the IMRT technique, the dose to kill the tumor cells is much more higher, so their recurrence rate will be much less. Means the IMRT, if you treat IMRT, if patient treat 3D compared with treat IMRT, the IMRT example, if you treat IMRT, your life expectation may be 5 years. Okay, if you treat 3D, you have maybe 3 years only. So after 3 years, this group of 3D patients, they may recurrence, that their cancer cells, their sickness may recurrence. So we have to repeat the treatment for this 3D group of patients. This is only an example. Okay. So the IMRT is a very different way to plan and treat patients compared to the 3D conformal therapy. As what I mentioned the previous class, the 3D technique, normally, if you want to get a very conformal dose, we only use a 4-beam technique, which will create a box field to treat the tumor. Okay, while by using IMRT, we can create as much as beams to create a much more conformal dose to the tumor. So it improves the treatment planning. And then in IMRT, some will not some, actually previously they will say this is the inverse planning. Okay, this one I will explain a little bit more later. So by using the automation and targeting multiple tumors in one treatment or dose escalation, overall it will improve the treatment delivery. Okay, why do we want to use IMRT? So because there's a lot of complex target shapes, because normally the tumor won't be a very round shape only. There is some very weird shape, like maybe later I can show you some example. It's not only round shape, and then there's here and there, not only one tumor, maybe like CA lung, they may have 5 or 4 lung tumor. Okay, then is much more confirmed radiation dose to the tumor, and then we will decrease the complications. For example, in CA lung, if we are using 3D conformal techniques only, we may hurt the lung, a normal lung tissue as much more compared to the IMRT technique. So if using the IMRT technique, we can reduce the pneumonia side effects, okay, compared to the 3Ds. So okay, it's also better tumor control. So if we need to retreat the patients where previously they have treated, so now we can treat again by using IMRT, because if previously patient have received a 3D treatment where their organ at risk dose is already reached the maximum. So if patient need to receive treatment again, 3D technique is very difficult to achieve, because it can't help to reduce the organ at risk dose, because there's a maximum dose for every organs. So by using IMRT, because we can create a very nice tumor dose while reduce their organ at risk. So by using IMRT, we can retreat this kind of patients with the maximum tolerance. So this one I will also share with you later. Okay, so there's many clinical trials have proven the effectiveness of IMRT over a wide range disease sites. So it improved the long-term overall survival, improved the local control, means we can control the tumor from not spreading to others organ. And then also the late toxicities is lower. Late toxicity, there is a acute toxicity and late toxicity. Acute toxicity means the side effect will occur now. Example, if we are treating head and neck cancer, their mucositis means the oral cavity is very dry, and then there is mucositis, how to say, so you will see immediate side effect for this kind of toxicity. This is what we call acute toxicity. Okay, means now if you show the side effects. While for late toxicities, example is maybe their lens, our eyes lens or our cataracts, cataracts. So if the lens receive higher dose, so it may develop the cataracts, which may be 3 or 4 years later. Example of acute and late toxicities means the lens, if you treat the lens with a higher dose, for now you won't see the effects. Later only they will see the effects. Okay. Then for clinical examples, head and neck cases. Okay, head and neck cases, we have CA tongues, CA nasopharynx, tonsils, larynx. Okay, so this kind of head and neck cancer is super very sensitive to radiations. So the for head and neck cases, there will be a lot of organ at risk. So we need to protect all these organ at risk by using IMRT. Okay, let's say from the left, this picture, this is using a normal 3D opposed lateral views only. You will see the spinal cord, the mandible, and the oral cavity receive almost 100% dose if you are using this opposed lateral view. Why you are using IMRT view, or you see from picture B, C, D, the increasing of beams numbers will reduce the dose to the OAR. As you can see from this picture D, the cord dose, they have saved the cord dose, and this two is our parotid gland. So we can also reduce the dose to the parotid gland. So the target is here. This red color, this is a CA tongue case. So the tongue will receive a very high dose, while we reduce the dose to the cords. Okay. So for head and neck case, there is a very serious side effects. If we are treating 3D technique, a patient may need hospitalizations because they can't eat. And then normally they will facing lost appetite, and then they can't eat. Then doctor will ask them to insert a feeding tubes. As you can see normally in drama or TVs. So patient will insert one feeding tube through their nose. Then they will feed the patient by using the tube, means they will put in the milk through the tubes direct to their stomach. So patient no need to eat by their mouth and trachea. Okay. So and also patient will also need to do some dental intervention things, because the radiation may hurt your teeth or tooth. It may so for head and neck cases, if patient have not a very healthy teeth, we will ask the patient go and see dentist first. If let's say the patient have a teeth where it's already loose and a very bad condition, and then we didn't do any action to this prior to the radiation, during or after the radiation, the teeth definitely will spoil, but this is not a major concern. The gum there, I mean the teeth and the gum may, how to say, the case won't be saying losing a teeth only. It will affect your gums too. It may it may also let your gums how to say, become a hole. It will create a hole, because the radiation, the teeth and the gums here will is very sensitive to this radiation. So the gum will be, will be a very super severe side effects to your gum area and the teeth. Okay. And then for another example is pelvis case. Last time I did show you the pelvic case. So it's a box field. So for this kind of patient, you can see my mouse here, right? So this patient is treating prostate cancer. So doctor also require patient to this doctor also control all these lymph node area. This is this blue shows the lymph node area. So by using a 3D, we can only use a box view where all these bowel, this is a bowel, means all the intestine inside will receive 100% dose. So a patient may develop diarrhea, and then there will be complications on their bowel and also their bladder. Okay, means if we continue treat this to a high dose by using a box field, patient may patient may develop bladder toxicity, where also in future they may can't control their urine because their bladder wall is already hurt. So by using IMRT, you see we can shape the dose according to the target. So by using IMRT, we can reduce a lot of bowel dose from this anterior area and in this area. So we can protect against also the rectal, here also the rectal dose, and what means while reducing the organ at risk dose, and the target will receive a very high dose. So this is the beautiful of IMRT techniques. We can save the OAR dose and the higher dose to the tumor. Okay. So if we want to start an IMRT planning treatment to in a centers. So because previously everyone is using 3D technique, so if you want to move from 3D technique to IMRT technique, it is not saying, oh, it's like playing a game, so you immediately just put in dump in every more field to the plan. It's not. So it is actually much more complex compared to the 3D planning. So we will need to understand very much on your LINAC machine and staffing. So every physicist, not only physicist, every physicist and radiographer, we will need to train them, because this is totally different from 3D techniques already. And then for new equipment also, we will need to do again, for the machine, we will need to do acceptance and commissionings again, because if 3D technique, we may accept the tolerance is higher. Means maybe your MLC multi-leaf collimator, the collimator the tolerance, okay, the MLC may receive up to, okay, let's say 2 mm tolerance, while by using IMRT technique, we can only accept the tolerance for 1 mm. So we need to redo everything, the acceptance and the commissioning, all the tools, and then collect all the data by using water tanks. So we will develop a lot of comprehensive QA, and then recollect all the data of the machines, and then we will dump into our treatment planning system. So from there, we have to tell, the machine, we have to recalibrate the machine and our treatment planning system to a tighter tolerance, okay, from 2 mm to 1 mm, okay. So this IMRT technique will requires a lot of collaboration for a well-trained multidisciplinary teams. Means if doctor insists want to treat IMRT, but the staff is not well educated in IMRT, it's better not to treat. It's better not to treat patients with IMRT technique, because else there may have accidents happens, which we hope not to happen. But in our generation or era, there's a lot of online teaching course under IEA or Globals lah. So there's a lot of online teaching, so we can learn from them. And then since the since the COVID time, there's also a lot online teaching by various countries. So as a physicist or radiographer, we always need to up to date to the current technologies and their techniques on how to treat on how to deliver a better treatment to a patient. Okay, later I will show you few examples on the latest technologies. Okay, so okay, in IMRT there's 3 different modes, depends on your machines. Okay, so the first one is static MLC, which we call step and shoot. So this one, the MLC leaves only the MLC leaves move only when the radiation beam is turned off. Means when the gantry move, the MLC will move to the according to the plan. But for this, while they are moving, the radiation is off. So when they are ready into the shape, then the radiation will be turned off. Okay. For the second type, we call dynamic MLC. In short form, is DMLC, sliding windows. So this one, MLC leaves move continuously while the radiation beam is on, but the gantry position is fixed. So it means when I am at gantry position 0 angle, there is a lot of small field for that beam. So the MLC leaf will move continuously and the radiation beam is on. For these two step and shoot and sliding window, this is a IMRT patterns. And then when the technology develop or improve from IMRT, they develop to Remap. Remap means volumetric modulated arc therapies. So this one, the MLC leaf move continuously and the gantry rotates around the patient while the radiation beam is on. This you have to imagine when the gantry angle is moving continuous at the same time, the MLC will also moving and the radiation is delivered. So this is why we said Remap will be much faster than the IMRT technique. By using Remap, for head and neck cases, it requires maybe 10 minutes only for one fraction treatment. While using IMRT, it may require up to 20 minutes because IMRT is from maybe 7 beams. So when the gantry angle is fixed, then only the MLC will move and shoot. So that's why it's require more time compared to the Remap. Okay, so nowadays there is very rare hospital using IMRT technique, except some of the government hospital and university hospital. Because those university hospital or government hospital, their machine is very maybe they have bought the machine like 10 or 20 years ago. So the machine is capable to treat IMRT only. So they can only use IMRT techniques. So some of the hospital will still use the IMRT technique. And sorry, anyone want to talk? So in private center, majority of the private center will treat with Remap, even though there is IMRT functions. Like in my hospital, we can still treat IMRT technique, but we choose not to treat because we want to save the delivery time to the patients and all the other patients. So if doctor prescribe IMRT technique for that patient, we will still plan with Remap techniques. Okay. Then when we want to treat, meaning most of the time wait, I have to do there's a question, how do I
Maybe I can read for you. So it says, meaning most of the time Remap is preferred compared to IMRT.
Yes, Remap will be preferred compared to IMRT. Normally now, the private center, they will not offer IMRT already because it requires much more planning time and the treatment times. Means physicists will use more time to plan, to create a plan. And patient also have to stay on the couch for a longer time. So now normally we won't use IMRT techniques. So now everyone is go to Remap, SRS. There's a lot more new things. But I still need to introduce all from 3D IMRT so you all know there is these things. At least you know previously there is IMRT. Okay, then when you go to work, okay, now it's okay, your center is only have Remap, is okay, but at least you know previously there is IMRT. For the current era now, even some hospitals have also 2D technique treatments. Means they don't rely on the treatment planning system. When patient come, they just do a simple simulation with a 2D technique, then they will just treat patients. But this will only happen in government hospital. I think they still for myself, I have worked as physicist for almost 14 years, but I never use 2D treatment. I never see how a 2D treatment technique. Okay. And then for all of you, I think maybe when you all join, 3D will be a very less chance also. If you join private center, I can say now the private center majority of their treatments are maybe okay like 60-40% 60% is treating Remats already, Remats and SRS. So you may have less chance to see how a 3D treatment technique. But still we need to know, because all this is a basic to Remat and SRS. The things is the same, just the planning technique is different. Okay, come back to when we want to do MRT techniques. So we will require imaging, means CT scan, for sure is a 3D imaging data set. CT scan, there is a MRI or PET-CT scan. So for this MRI and PET-CT scan, we will need to fuse with our CT simulation image, so to see clearer where's the tumor, okay, with contrast injections. Means patient have already do MRI and PET-CT with contrast or the FDG uptake. Then physicists will need to fuse this with the CT simulation image. Okay, later I will show you how is it work. And then by using this MRI and PET-CT, the fusion, the doctor will have a clear guides for their target volume and also our OAR, because sometimes it's very difficult to see where is maybe the brainstem. And then for doctor is the tumor. For doctor is clear to see the tumor. So for patient immobilizations and positionings, for 3D planning, maybe for example, pelvis case, if for a 3D treatment, the radiographer will just position the patients just lying on the couch without using any immobilizations tools, because the 3D, the tolerance we can accept up to 5 mm. We can accept up to 5 mm, okay? While for MRT, we can accept up to 3 mm only. So for radiographer to reproduce the patient position daily, they will need all these immobilization tools. So for this pelvis case, they may use body mold. There is a body mold is as we will let patients sleep on a spatial cushions. Then we will vacuum the cushions according to the patient's body. Okay, this can make sure every day they reproduce the same position during their treatments. Okay, so you see, treatment delivery require with millimeter precision. Means when what I say just now, the tolerance is 3 mm, and then the patient motion management. This motion management means we limit the patient motion. If you are lying still on the couch, you may have a mild motion where we can't see. So by using this immobilization tools, we can limit their motions. This is external motions only. So for the era now, we even have internal motions management. Means when we can restrict your lungs motions, your bowel motions, by using there is a lot of new 4D technology. I will show you later because just nice we have one patient is using this 4D motion management. Okay, so when the patient want to treat the receive the treatment, prior to the treatment, we will do another imaging where we call Cbct. The full name is cone beam CT, and means we will do a small CT scan before the treatment delivered. So this is to make sure the position where radiographer set is 100% match with the treatment plan. Okay, once this everything is matched, then only we can deliver the treatment to the patients. So and also before we treat the patient, physicists will need to develop a patient's pre-treatment QA. So we have to cross-check everything, the accuracy of the plan you develop, plan you develop with the machine functions, the MLC movement, everything is passed, then only we can deliver, we can make sure the treatment is delivered safely and accurate. Okay, so back to this one. What is an intensity modulated beam? Okay. Yeah. So for a 3D normal radiation beam, it has a flat profile. Even when conformal, each beam has a uniform fluence. Okay, for this example, is a 5-beam technique, 5-beam 3D techniques. So every beam contribute the same flat profile. You can see this purple color is a flat profile to create a fluence. This one to create the fluence to become a uniform. No, I have to say these 5 beams will create the same things, flat profile to create these fluence maps. Okay, so while the intensity modulated beams, as just now when I mentioned, the MLC leaf will move during a gantry positions, means there will in one small beam, beam number 1, inside beam number 1 they may have a lot small field. Like the previous lecture, I teach you the field in field technique. I did teach you the field in field technique. Yes. So by using this called field in field technique, there's a lot small field in beam number 1. Maybe beam number 1 have 20 small field. So this 20 small field will create a non-uniform fluence. You will see these things. So beam number 1 and all these 5 beams will have different fluence map. So when they combine, means maybe beam number 1 will contribute 10%, beam number 5 20%. So all these 5 beams, when they combine, it will create a non-uniform fluence. This photo and this, okay, this it will show us a high dose area at this. Actually, this is you have to imagine this is a 2D map. This example is a prostate cancer. So at this red color, actually it is show the target here to receive a very high dose. While for this 3D technique, it create a flat dose. Like previously, I showed you the whole box view will receive at least 95%. So it will receive a uniform fluence map over here compared to this IMRT. Because for example, for this 3D, doctor prescribed 50 gray. So overall is 50 gray. But with IMRT technique, maybe doctor said, okay, for this prostate area, I want to receive 50 gray, while for upper part, lymph node area, I want to receive 40 gray only. So this why this fluorescence map will create hotter at this prostate area while lower dose to these lymph node areas. What's the questions? Let's check back to.
You want me to read for you?
Mm.
That mean majority patient will use patient mode for scanning in CT sim for patient QC check after a few time after treatment. So no more manual position breastport.
Huh? Again?
That mean majority of the patient will actually use patient mode for the scanning in the CT sim for patient QC check after a few time after the treatment. Yeah, I think
After the treatment.
question. Yeah, so no more manual position breastport.
Oh, still depends on which treatment technique doctor offer to patient, because okay, for current economy, they still patient choose to treat 3D compared to IMRT or Remap because of the price. The Remap price will be maybe double or triple compared to 3D. So if patient choose 3D, we will still do the normal immobilization positionings. I have to read the questions clearly lah. Sorry, yeah. I scared I don't know how do I go back. Here. Majorly we use patient mode for scanning in CT scan for patient QC check. No more manual for scanning in. For first time, we will still CT sim the patient with everything of their. Let's say this is a breastport patients. We will still use the breastport for the patient for IMRT or for the Remap. Okay, but for patient QC check. Patient QC check means, if I'm not wrong, you are mentioning about the IMRT pre-treatment QA. This treatment QA is not with patient. This one is just with the phantom to check where the plan and the machine output is delivered correctly to the phantom. Means we mimic the patient, we mimic the we use the phantom is like our patients. So we deliver the treatment plan to the patients to ensure the treatment delivery is correct before we deliver to the patients. So for more of scanning in CT sim for patient after few. So after a few time, okay, if the pre-treatment QA is passed, so we wouldn't do again a QA for that patient. Means every fraction patient have, let's say patient have 15 fraction, patient will still treat with their first positioning device. Means every time they will treat with breastport. Okay, am I answer you correctly? Yeah, because I'm worried I'm misunderstand your questions.
Azmi, maybe you can just unmute yourself.
You can PM me later. Set up, okay, yeah, set up. That mean not all patient will use a patient more. Yes, not every patient will use the patient more. Depends on which site they want to treat. If head and neck, they will use the BDS more. If breastport, if breast, they will use the breastport. It's very depends on their treatment area. Okay, understand now? Okay, then we will continue. Okay, just now I mentioned what's the difference conventional and IMRT. IMRT just now I mentioned inverse planning. So in 3D conventional, it is a forward planning. In IMRT, we call inverse planning. Why do we say so? Okay, in 3D, we will specify the numbers of the beams, the energy, and the entry angles Then only we ask the computer to calculate the dose. After the computer calculate the dose, we will see how good is the plan. If it is unacceptable, we will change the relative beam weighting, or we add in wedge angle, or we add in field. Then we calculate again the dose until you accept the plans. This is called manually. You will need to key in all these parameters until you get a very good dose distribution plan. Okay, while for IMRT inverse planning, we will tell the computer, we specify the dose volume constraint first. Means we will tell the computer, I want target 70 gray, but I want spinal cord maximum dose is 45 gray, the eyes is 45 gray, and so on. Then the planning system will develop the plan for you by so we no need to of course you still need to put in the beam, how many beams you want. Okay, maybe 5 angles, then only you put in this volume constraint to let the computer works for you. So once they give you the plan, you will evaluate the plan. The difference from the 3D you will change the beam weighting or you add in the wedge. While in IMRT planning, we can't adjust the beam weighting or we add in the wedge. We won't do that. There is also no options for you to do that. We will only need to change the relative dose constraint. Means for the first step here, maybe example, now the plan, they give you the spinal cord is 50 gray, where I don't want to accept that. I want my spinal cord 45 gray only. So for your plan, you will need to adjust the cost functions of the spinal cord. You have to edit a bit your cost functions maximum dose. This one very difficult to say. You are very difficult to imagine now. I show you later is better. Okay, so this optimization loop will continuous until you accept your plan. Okay, are you clear for this one? I am worried you all can't imagine for this one. Or maybe later I show you example first. Okay, so there is still some problem when we are using inverse planning. So there's factors affecting the results. So the beam orientations means for IMRT beams, normally we will use at least 5 beams. Okay, so the angle physicists will need to put in which angle, which gantry entry angle. Maybe you want 0, 30, 60 or 90. So this beam orientation will also affect your plan. Maybe the 30 gantry 30 or gantry 90 is not good enough for your plan. So maybe later after you optimize your plan, you will need to adjust your beam angles. And then the numbers of beams also will affect. Of course, the higher beams will create a better plan. But you in balance, you will need to think a 5 beam plan with a 11 beams plan. Definitely the 11 beams plan will give you a very good result, but this will cause the treatment delivery times will be higher. Okay, and then the parameter and the dose constraint you put in also will affect your plan result. Okay, the algorithm, calculating algorithm and the objective functions, this one will also affect your plan. This is what I mentioned, the cost function just now. So everything add up. Actually, experience is goal. So means you compare a 100, you have do a 100 case compared to those you have only planned 20 cases. So for sure the 100 cases planner will win the 20 cases. planner. Okay, experience is goal. This is after how you do all this plan, you learn from you learn one by one, and then there is also a very important factors in IMRT only. IMRT. IMRT, like I mentioned just now, is created by minimum 5 beam to maximum maybe 11 beams. In IMRT, we can't create a opposed gantry angle. Means in 3D, we have a 4 field angles, 0, 180, 90, and 270. In IMR, means in 3D, 0 and 180 is opposed angle. Okay, they will share the same MLC movement. In IMRT, we can't do that. If you do that, means these two angles, 0 and 180, they are sharing a same non-uniform fluence, where this one wouldn't benefit to your plan. You wouldn't get a good plan because they are actually 50-50% same contribution to that plan. So for IMRT, we will choose different angle when it's not opposed. Means if you choose 0 but you still want a beam from posterior, you can't choose 180. You will need to use maybe 170 or 190. So to create a different fluence, different MLC movement for that field, means a different field in field for that beam. Okay, am I clear? Okay, if there is no question, then I will continue, because actually today our section for IMRT is very complicated and very difficult to imagine. When based on the textbook, it's very difficult you can understand all this. IMRT very depends on treatment planning system. Treatment planning skills, but we are still need to understand the basic and the requirements. Okay, so okay, the IMRT plan create is I have briefed you all for that, and then in this part, so all this how can we not justify, how do we know the protocol, means how much dose we can accept for spinal cord, brainstem, eyes. So in global, there is a normally this journal of the ICIU, as last I mentioned, the ICIU 50 is for 3D planning technique. This ICIU report 83 is for IMRT. Even IMRT or Remap is all this. Okay, so in this journal, they spell out all the definitions of the GTV, CTV, PTV, and the margins. And then the target coverage means how much is much, how less is less. Means maybe 95% of the tumor receive 70 gray, but at the same time, for your PTV, you cannot get more than 110%. For example, you cannot get more than 10% of 70 grams. You cannot get more than 77 grams. All these, all worldwide, we adopt from this ICIU report and this constraint. Now normally people you use this we call contact paper. In this contact paper, they will show you the every dose constraint for all the organ at risk. As I mentioned just now, the maximum for spinal cord is 45 gray, something like that. Okay, for every physicist, we need to know all of this. means there is a guide for you to create your plan. Okay, even though if doctor tell you, okay, I want 70 gram, yes, you receive the PTV is 70 gram, but are you sure your organ at risk receive the maximum dose where they can? Means if you create a 70 gram but your spinal cord is 60 gram, oh, you will kill the you will kill the patients. Okay, so you need to strictly follow all these protocol to deliver a safe treatment to the patients. Okay. Okay, then okay, come to patient specific QA. Just now I mentioned every IMRT case we will need to create a patient specific QA. So why do we need it, and why 3D planning technique we don't need it? Okay, 3D planning we only use, let's say, 4 field is a box field. Okay, just now I mentioned these 4 beams is equally share a flat profile, means the same pattern. One each beam share a same pattern, the APPA share the same pattern. So while for IMRT technique, even though you create a 5 beam IMRT plan, inside these 5 beam, like just now I mentioned the field in field, the small segment, they may sum up 100 field in fields. So that means in these 5 beam, total up there is a 100 segment. So this 100 segment is different field size, or maybe segment 1 you have a 2x2 field size, segment 2 you have 4x4 with different small MLC segments. So for this patient specific QA, we will need to identify the hazards and the failures. So we need to evaluate the consequences of it. Okay, so means after you deliver 100 segments during this pre-patient QA, you found your plan is fair, means they will give you a result. If you found your plans is fair, means there is something wrong in your plan or your machine problem. So as a physicist, you will need to identify what has goes wrong. So okay, back to what has goes on before that. So what do we need to verify? Okay, we will transfer the plan from TPS to the LINAC first. Then we will is to a phantom. This one also I will show you how we create a patient QA plan later. So after you done this, then only we will should the deliver the treatment to the phantom. Okay, so okay, what do we need to verify? Okay, so the verifications to the intensity modulated field boundary. So means if the shape is triangle, let's say if the shape is triangle, your patient treatment QA, the shape will also triangle. Okay, if it's come out diamond shape, means your plan is fair. Okay, so it's in that independent calculations, verifications that the machine's instruction driving the leaves produce the planned absorb dose distribution. Means if you check your MLC, the MLC leaf produced correctly or not, means supposedly the MLC should have should be at position 2 cm, but when you shoot the plan it is at 4 cm, means your MLC there is something wrong. So you will need to counter check why this happens. Okay, number 3, comparison of the absorbed dose distribution in a phantom. So with the calculated by the treatment planning computer for the same irradiate, okay, means this patient, let's say you have created a plan 70 gray to let's say 70 gray to prostate region. So at the same time, when you do the QA, your phantom will also receive 70 gray. Okay, if your phantom receive 60 gray or 75 gray, means something wrong. Okay, then comparison of the plan leaf motions with that recorded on the MLC logs file. So this is what I say just now, the MLC leaf motions. Some machine we can generate a MLC log file from the machine, but while some can't. Normally, if you can't, we will use a 2D technique, means we will shoot all the beams on a film. Then only you compare with a fluence map. This one later I'll show you an example. And then confirmation of the initial and final positions of the MLC for each field by a record and verified system. This record and verified system is a system where integrity between the machines and the treatment planning system. So it means we send the plan from treatment system to this record and verified system. Then only the machine will grab the information from this system to treat the patients. Okay, so we will need to confirm every field created in the system is correct or not. So, and also we can also create an in vivo absorb those measurements. Okay. So for patients QA, there is where there is a lot different QA tools from different company. We may use electrometer, array detectors, map check. This is just the name of the QA device. So this is a PTW octavus, check, matrix, and this one is delta 4. Imit is next next slide. So in my hospital, we are using these octavus and delta 4, but majority of the time we will only use this delta 4 because we find it's much easier, and this one is 3D 3D QA. For the PTW octavus is only create a 2D fluence map. Okay. 1 minute. Okay, so this one what I mentioned just now is a MLC comparison plan leaf motions, and which one, and okay, this one is check the MLC. Okay, so we will put a film on this machine. This is a machine gantry head, so we will put a film and then we shoot all the beams to that film. So at the end, you will see this fluence map. Then we will compare with our TPS. So there is a lot of software where you can compare this kind of fluence map, but I never do this in my hospital because we don't have film, and then we don't have the developer. So normally we will use the others QA tools to do all these pre-treatment verifications. So this is an example, and then fluence map of each beam using Imit. This is how we do in my system in my hospital. We have a Imit. This is called iView GT for Electa machines. It is a mega wattage. How to say? If you deliver all the beam on this panel, okay, like this panel is the film. Okay, then okay, so this all this is type of QA tools you may choose to do for your patient pre-treatment QA. Okay. Then, okay, now I will explain when the verification is perfect. Okay, you do the QA, but then how do you measure it? How do you know your QA plan is passed or failed? So there is a criteria developed in since 1998. So we will call this gamma index 3% and DTA 3 mm. This one you will need to study yourself, because if I need to explain in details, it will take a very long time. It's not very easy to understand. Okay, this method they developed to enable the comparison of dose distribution in a quantitative manner by calculating the gamma index and the minimum distance in the normalized dose distance space. By reading this sentence also, we will very confused. So that's why I said it's very difficult to explain in details on this. So normally it is the dose difference and the isodose point distance. Okay, for example, okay, this is a patient-specific QA result after you shoot everything by your QA tools. So by using their software, the software will help you to give you this result. Okay, from sagittal plan, transverse, or coronal plan. So this is the result you will get. You see, gamma index just now I said 3%. So 95.9% from this for this plan, and 97.5% with DTA less than 3 mm. DTA means distance to agreement. So normally, okay, normally here I never mentioned. Normally we will accept the result is you must have the result combine all these more than 95%. Okay, in your system it will show in your software setting you will need to set what the passing criteria. So it's 5% of all these DTA and gamma index. Okay, so if you, let's say if you get 94%, you can't say 1% only, never mind lah. No, you can't. So you need to go and find out why the 1% fail. Okay, then dose to the patients equals to in vivo dosimetry. Okay, traditionally in vivo dosimetry have been point dose dosimetry using TLD or diets. However, a point is not representative of an IMRT or Remap dose distribution. So previously, in vivo, they only use 1 point. Means they will put 1 TLD or 1 diode on the patient or the phantom to say, oh, this is the QA result. But for whole plan, imagine if your plan is 20 cm length, while you only measure 1 point, where this is like a ridiculous, because one whole plan you only measure 1 dose. So how about the other point dose? So previously, last time where before they develop 3D or 4D QA tools, so normally they will do this point dose. So last time they will do not only 1 point, so they will do a multi-point. Maybe your plan has 100 segments, maybe they will do 10 points or 20 points. It depends on you how many points you want to select. But then how can we verify all this is correct? Okay, so by in the technology evolved, they have create a in vivo dose in 3D. So how can we do this in 3D? Okay, last time is in 2D, so now we go to 3D. So we will call this as Imit dosimetry. Okay, So with this Imit dosimetry in vivo dosimetry means you measure the patient's treatment plan with patients on couch. Okay, like just now we use the phantom only to mimic patients. That is called in vitro. In vivo means real patients on couch. So in this in vivo dosimetry, there is a software we call dosisoft. By using the Imit, just now I mentioned the panel where we can where it is the function is like the film. Okay, when the patient is lying on the couch and where they receive the actual treatment delivery, this Imit system will also simultaneously receive the beam to this panel. So while patient finish the treatment, they have also collect all the beam delivery fluence map to this Imit. Then only by using dosisoft software, they can analyze the result where what the patient treatment is correct or not. This is called real patients QA in vivo dosimetry. Okay, not all center have this because this Imit dosimetry is quite new, maybe 3 to 4 years back. Maybe it's just not announced, just frequently widely used in radiotherapy area. In my center, we have this since 2020, early 2020. But this one requires a lot of effort to measure all the data and we also need a collaboration from the radiographer because when they treat the patient, they will need to remember, turn on all this. Then only the physicist can analyze the data after patient done the treatment. Okay, so pre-treatment QA is very essential when you setting up a new things. So by using the Imit, we will reduce the QA burden per patient because normally we will need to move in all the phantom into the linac room. We have to set up everything to get our patients specific QA. But while using this Imit in vivo dosimetry, we can somehow reduce our time to set up all these, and this is one in vivo means with the real patients. We do all the QA in real patients. Okay, ideally, we will need to verify all our patients with in vivo dosimetry, but this also involve cost and the manpower efforts lah. Not because the invest and in this kind of software is not cheap, and also not every one know there is this kind of things. Okay, so that's why I say as a physicist we also always need to study online and follow the development of all the techniques and the QAs. Okay, so before we go to the real cases, I think I will stop here. Shall we go for breakfast?
Yeah. Does anyone has question? Any question about the topic?
It's very blur for them, I think.
Yeah. So if there is no question, so we can go for a break first. I think we'll back around 11:20.
I'm okay.
Okay. So back at 11:20.
All right.
Welcome back, everyone. Miss Teo, are you ready to continue?
Yes.
So there is actually a question in the chat box. If you can take a look.
Most of the physicists struggle with Remap. If for new physicists, yes, it is. So with the, like in my center, we have a plan for a lot of Remap cases. Of course, initially we also very struggling in Remap because we don't really understand the how to use the cost functions of parameter to play around with that. So after few years or after many cases that we plan out, then we have established so-called template. So for example, for every CA prostate cases now, we will directly load the template with existing cost function created before. So with that template, we can done our planning just within one click. So means one round planning, then is the Remap plan is already done. Of course, not every patient's plan with one click can be done because it's also based on how big is the tumor or what's the OAR size. So if you have plan, that's why we said experience is goal. So with a lot of experience, then you will very fast you can plan out a very good Remap plan. And then is there any apps or software I can train myself or for unfortunately there is no any free software to train it. It's very good you know the Pronos apps for contouring. So before that 1 minute I have to get my son go out from this room. 1 minute. And then because all these we met MRT planning, we need a license to the software need a license. So it's not a cheap license. And then with all this one also need all the data for us, your machine data to put in a plan. So there is no free software for that. And then for everyone, I think not everyone knows this Pronos online based contouring web page. So if you
My
really
student know because I give them as assignment for their anatomy
then very good because
subject. Yeah.
actually for all my fresh graded not fresh graded and newly joined physicists, I will make sure them to learn all the contouring for this prono. So every physicist will contour the same things with the guideline under the prono. So for if every physicist contouring the same things, so our template for the Remap plan will be much more easier when you plan it out. So if I contour, for example, I contour the bladder is an apple shape and the other contour the bladder is a round shape. So the cost function in the Remap template will be very difficult based on different shape because the parameter set in will be very difficult for the system to differentiate. And then, okay, and then before that, last lecture, I don't think I teach about the DVH and the EQD2. I don't think I teach them to calculate. So I will teach about the EQD2 first. Then let's share my screen. Share screen. Share screen. Okay. So before we go on to the real cases, last lecture I missed out to teach you all how to calculate this EQD2. Okay. EQD2 stand for equivalent dose. Okay. These all based on 200 centigrade. Okay. So there is a short, I think you all know what is alpha and what is beta. So there's a short formula where, yeah, the formula will be dose plus beta, yeah, plus 2 plus beta, or alpha beta, sorry. So example is when the doctor prescribed 40 gray in 15 fractions, this is 40 gray in 15 fractions, where per fraction dose is 2.67 gray per fraction. But all the radiobiology, they all calculate the dose is 200 centigrade. Okay, so we need to know actually in EQD2 how much patient is received with this 40 gray. So by using the formula given this one, we will 2.67 plus. Normally the normal tissue, this one is equivalent dose for normal tissue. The alpha beta, we will use value 3. So okay, can everyone calculate? Can you all calculate this one for me? What is the factor? You can type in the chat box. Okay, 1.134. So this is the factor. Okay, how do we get the equivalent dose? Equivalent dose equals to, sorry, this is small d. Dose times, this one is total dose, d capital, and this one is dose per fraction. So actually for this 40 gray in 15 fraction, we will need to multiply 1.134 with 40 gray. So in actual, the patient will receive 45 and 36, 45.36 gray. So do you understand this one? Okay. Okay, so now you understand this one. Then for another example, 60 gray in 20 fraction. Okay. EQT2 equals to, okay, calculate everyone and give me the answer. You get the answer? Okay, 72 gray. So patient actually received 72 gray. Okay, this is just the patient received total dose. Okay, so how can we apply this one to our, okay, let's say, okay, for spinal cord, the maximum dose received is 45 gray. Okay, EQD2, this one EQD2, 45 gray. So in these 60 gray prescriptions, how much maximum I can receive for spinal cord? Okay, you can start to calculate now. Do you understand what do I need? So I give you 1 more minute to calculate the answer. If you have answer already, you can type in chat box. Yeah. Okay, there's an answer 37.5. Is there others answer or you don't know how to calculate? So can Prema explain to others how do you get 37.5 and what is the meanings? You want to unmute yourself and I just make the D as the subject. Using the same formula.
I mean, I use the same formula for EQD2, which is capital D times with D plus alpha or beta over 2 plus alpha or beta. So I just make the capital D as a subject. So EQD2 is 45 and the D is 3, alpha beta is 3, something like that.
I'm not sure you understand my questions. Your answer is correct, but what do you explain is a little bit, it's not correct. So I'm asking, okay, for this 60 gray, okay, in 20 fractions, what is my spinal cord can receive? Because this actually EQD2 for this 60 gray plan, this one is hypo fraction. You see, 60 gray in 20 fraction is 3 gray per fractions, where it's much higher from the basic 2 grade. So actually patient is received 72 grade. So in radiobiology, we all consider the dose calculated in 2 grade. So in spinal cord, the maximum is 45 grade, okay? Okay, 45 grade, which means in this plan, this prescription, 60 grade in 20 fraction, my spinal cord has to receive less than 45 grade, okay? Just now, when we calculate this one, our factor is 1.2. So everyone get this 1.2, right? Means 60 with 1.2 factor, we will get 72 grade. So for my spinal cord, I can receive maximum, 37.5 grade in prescription, 60 grade in 20 fraction. Am I clear? Actually, we will just use the white 1.2 factor in this 45 grade. For example, let's say brainstem, the maximum dose is 54 grade. So we will just divide 1.2 equals to what? So in this, with this prescription in my plan, I can only allow maximum dose to spinal cord is 70.5 grade. Okay? Am I clear for this one? Because before, else later is very difficult to continue our teaching if you can't understand this one. Anyone have problem or don't understand? This is very important when, as a physicist, you will need to always remember this formula. Those. Okay. Okay, you need to remember this formula. So if there is no questions, then I will proceed to the real patient case. Okay. So this case, okay, let me go. This is an example of a CA prostate case, okay? So after doctor contour the target prostate and seminal vesicle. Let me doctor contour the prostate and the seminal vesicle, and then according to the guideline where global they do have a lot they do a lot of research, and then they develop a guideline where how much is the PTV you should expand, and then after doctor apply those guideline on her drawing, so this will be the PTV. Okay, there is a 3 dose volume on our PTV, but at the end, doctor want to treat these patients with 55 grade over 20 fractions. Means my PTV 1, the blue color, is my final target volume. So this, okay, this blue color is my PTV. Doctor want 55 grade all over this target volume, while physicists will need to save bladder and the rectum dose. Okay, rectum and the bladder dose. So normally in CA prostate cases, we will have a protocol for patient where we call bladder and rectum protocol. Bladder protocol means we will need patients to go to toilet first, and before simulation, we will ask patient go to toilet, and then we will make him drink 4 cups of water. Then he will need to wait for 40 minutes. This is the guideline in my centers. 4 cups and 40 minutes. Okay, 4 cups and 40 minutes. So by using this protocol, we will need to make sure patient bladder is extended. Okay, this helps to reduce the bladder toxicity while we push up the bowel, the small intestine superiorly. So this will reduce patient side effect. So we will reduce the chances of diarrhea. Okay. And then for the rectum, doctor normally will prep the patients before they come to the simulations. So if the rectum is full of feces or a lot of gas, we can't proceed the simulation because this one is very difficult to do a treatment plan, and the toxicity to the rectum will be very difficult to judge day to day. Okay, so with all this protocol, once after 40 minutes, we will expect the patient bladder volume is extended. Then we will perform a scan. Okay, so we will perform a scan when the radiographer check if the bladder is well extended. There's a big volume of the bladder, then they can perform all the simulations. Okay, if the patient's bladder volume is still very small after 40 minutes, we can't accept this CT image because this one for sure the Remap plan with all the tolerance DBH will be failed. So what we do, we will either wait for another 10 minutes or we ask patient to drink another 1 cup of water. 1 cup is about 150 ml lah. Okay, so after another 10 minutes, we will scan again. If the volume of if the bladder volume is big enough, then we will proceed the scan. And then once they've done everything, they will send the image to physicist. So for example, okay, this one, why do I say it's very important? I can show you another case. This case. Okay, as you can see here, we have 2 scans. For this patient, I have 2 scans. Bladder volume, we scan at 20 minutes and 30 minutes. Okay, so I can show you the difference. Okay. Okay, the left is scanned with 30 minutes. So the right is the scan after 20 minutes. So from here, you can obviously see the bladder difference. Okay, the red color is 30 minutes volume and the blue color is the 20 minutes volume. by difference 10 minutes, the bladder volume is different. So for this patient, actually, because our standard protocol is 4 cups, 30 minutes or 40 minutes. For these patients, with the 20 minutes volume, bladder volume, we can achieve all the bladder DVH. So I can tell my radiographer, this patient you can treat after 20 minutes. Means patient no need to wait until 30 minutes, then only can treat. So in this kind of arrangements, patient can save waiting time for 10 minutes. Okay, understand? So for this plan, we will directly use the 20 minutes to do a remap plan. Okay, now I show you the plan. So this is a remap plan. We create a plan with a full arc rotation with this one red color from 180 to another 180. So we call full arc. For this plan, the parameter can see here, maximum numbers of arcs means you put one beam is actually is 2 arcs. One beam equals to 2 arcs. Means this patient, when the treatment deliver, we will perform 180 counterclockwise to another angle, and then the another counterclockwise and clockwise. Okay, so means 2 full arc for the treatment delivery. Okay, so for remap, there is a lot parameters to play around, unlike the 3D planning technique. So in this remap plan, we can control the maximum control points per arc. Maximum control points means how many small field in field you want to control. So we limit this plan maximum per arc is 240 points. Okay, you can put from 2 until 1024 control points. But of course, if you put 1024 the maximum number, the plan also wouldn't give you 1024 control points. It will stop automatically when all the target and the OAR achieve the tolerance or achieve the DVH where you set. Okay, it's not means you want them to put in 500, then they will give you 500, but they won't give. If let's say if you set here 240, it won't give you 300 points. Means you restrict the plan less than 240. It may the plan at the end the plan may come out 100 points, 200 points. Okay, but it won't give you more than 240 points. Okay, so minimum segment width means my MLC, each segment the minimum width is 1 cm. Okay, I can show you here. This one. Okay, just now when I said there is a lot small field in field segment. Okay, this is what I mentioned. This green line is my MLC, the multi-leaf collimator. This small segment. Okay, for remap, you see for this beam clockwise from 180 to another 180. For this beam, I have total okay, segment. You can see here how many segment. Okay, I can you focus on this. Wait, let me enlarge. You focus on this segment. Every because this one is Remap, so every arc angle means from 180 continuously increase 180, 190, 200, 270, okay, continuously. There is MLC movement, okay. I will play this one for you to see what is the okay. Okay, you can see here when okay, this now is gantry 180. When I rotate the gantry, every gantry angle will have small segment. You can see clear or not? Let me adjust a bit the contrast. Okay, now you can see better. Okay, so you can see the MLC is different when the gantry angle is different. Yeah, this here is very difficult to show you. Okay, you can see the difference. Small segment. For prostate, it will be a very large segment plan. So actually, this plan will consist of, let me see how many points. 273 segments to deliver to the patient. So for this plan, there will be 273 segments. Combine all these will give you a good Fluence map with a dose distribution where 55 grade. Okay, for from here I can show you control point summary. Segment some. Okay, let me see this one. Okay, you can see here from gantry 183.8, there is so then increasing until all these angle. So every gantry angle there is a control point. Every control point there is a different MU, okay, and also different field size. So every point with small MU combine everything will give you a plan with total MU 925 MU. Okay. So there is another, I can show you this one. Not this. Okay, this one is the Fluence map. Where just now remember they put the film on the gantry head. So this is the Fluence map for total beam, one beam. Okay, so you can compare this Fluence map with the film where you shoot. Okay, this is the example, the Fluence map. And then what else I can show you here? Segment details I have shown you. Okay, so how do we generate a Remap plan? As I mentioned just now, there is a lot of cost functions parameters for you to play around. Okay, for yeah. Okay, first, once doctor done the contouring and after you contour all the OAR, organ at risk, in this prostate plan, we will have bladder, femoral head, and rectum. Okay, This is a super simple plan for us. Now it's super simple plan. So by putting, at first, you will need to prescribe, do the prescription, 55 gray, 20 fractions. Okay, you have to decide your beam. So we put one beam with 6 MV filter free.
Sorry, Miss Teo.
Yes,
When will we use the counterclockwise or clockwise?
it's up to you. You can use clockwise only, but because we want to save time, normally, I mean the beam angle you can decide yourself. But normally for Remap, we will straight will give one full up, and then when the you imagine when the gantry turn from counterclockwise from 180 to counterclockwise. So from here to here, so the gantry, I rephrase. For this plan, we give one beam, two up. Automatically, they will give you one beam, one arc with clockwise, and another arc will be anti-clockwise. So the machine, the gantry, no need to turn here and there. Okay. So you can also put this plan with partial arcs like 180 to 270. It's up to you and depends on the which side of tumor. Okay. For normally we will straight away use one beam, two arc. So because we already established all these template for prostate case. So for, let's say example, I show you later the lung case. Then I will choose another angle for that patients. Okay. So for this, okay, before that we have put in the beam. Delivery mode, you can see here is Remap. I can choose 3D conformer. I think DMLC where I teach just now, DMLC or step and shoot. Okay, but as I tell you, we won't do any IMRT in my center, so we will straight away use Remap. Okay, so treatment unit, it means which machine you want to use. My center, we have two machines, so I have to choose which machine we want to treat this patient. Photon or electron algorithm. This one is calculations algorithms. So different treatment system have a different algorithm. For Monaco, this system we call Monaco. We use Monte Carlo simulations algorithm. Then energy, you can also choose 6 MV, 10 MV, filtering free, 6 MV or 10. Okay. Then this MU per fraction will be generated after the planning system done the calculations for you. So SSD is depends where do you put your isocenter. Okay. Then for this geometry, yeah, so slow. Okay. Okay, you can choose gantry start angle. See, for this plan, I put clockwise start angle from 180 for 360 up. Okay, for example, I want a 90-degree up. Then you will just key in here. Okay, now you can see my beam is this red color. So it's only a 90-degree, this area only. Okay, so and this inclino means we will set every 30-degree, they will have a beam. Okay, this one you can set from 3 to 60-degree. Of course, if 60-degree is too much, means every 60-degree then only have a beam delivery. So normally our plan default is 30-degree. For those very high dose to and a lot of ORR plan, we will choose a lower value over here. So you can also set your collimator angle. your couch angle. So this field, unlike the 3D, normally 3D we will set the field size for the plan 10 by 10 or 20 by 20. So for Remap, we will set it auto. Of course, you can set fixed, but it wouldn't encourage to do that because we want the computer work for us. We don't want to fix them how they can perform. So normally we will put an auto field size. So you just tell the computer anything you can do, provided you give me a very good plan. Okay, treatment 8. So for Remap, as I mentioned, there won't be a wash options in Remap plan. So we will have only bolus. Bolus is a tissue compensator, but for this pen, we don't need a bolus, so you can't take that. So for if you click this couch function, means we will put in the couch factor to compensate the couch intensity, because there is some normal tissue, the normal tissue what do we call that, normal tissue density normally is 1, but couch, you can see here, couch is, there is some minor electron density over here. It depends on which couch you purchase. So normally we will put in this couch factor inside for the computer to calculation purposes. So after you key in all the beams parameter and the geometry, now we will go to this IMRT constraint, where I mentioned just now, this is all the cost function we can play around to tell computer this is what Y wants. So by default, every plan you will need a PTV and one OAR. You must have this, at least these two, then only the plan will be optimized. Okay, so for this plan, my doctor give me a PTV1 as my target volume. So there is a lot cost function to play. Normally for planning for PTV, we can choose, you see, add cost function. This is the list for Monaco system where we can play around for the cost function. There is target EUD, target penalty. Okay, normally for target, we will need to choose either target EUD or target penalty. Target EUD is more to a radiobiology functions, where it's a little bit difficult to play around. So normally we will directly use target penalty. So target penalty here means we will tell the computer, I want 55 gray for this PTV1. Okay, we will select target penalty and then 55 gray. Okay, so example, this one. So I will need to tell computer require parameter for this PTV1 55 gray, and then I also need to tell the computer I need minimum volume of 95% to you need to give me at least 95% of the PTV1 getting 55 gray. Okay, so you need to tell them how much do you need. You can also put 100%, okay, but it works very hard. Okay, according to the DVH set, we will need to have at least 95%. So normally we put 95 for the computer to know I need only 95%. Okay, then for this quadratic overdose, there's this another cost function. This cost function will normally limit the, I can show here. 1 minute. I will, okay, do you see Okay, you see this one, this brown color means I tell the computer I want this area not more than 58 gray. See, maximum dose not more than 58 gray. Okay, for this RMS dose access means how does the computer calculate the things. This one is only applied in Monaco system. Is if you are using another system, it will be different. So I'm not going to explain this one in here. I mean this value we can play around for your planning. Okay, and then after we put in the PTV target, okay, now I have dialed the computer. I want PTV1 55 gray, while you cannot more than 58 gray. Okay, so then I have to put in my OAR. There is a bladder and the rectum. So for bladder, as you can see here, there is parallel and serial cost functions. So parallels normally we will apply for parallel organs. Means, for example, parallel organs in our body, kidney, eyes, carotid, where there is two same organ in our body. Okay, kidney means there is left and right kidney so this is all called parallel organs. Okay, and for serial cost functions, these apply to those organ at risk where if the dose more than the maximum dose, it will cause a very serious side effect to the patients. Means if you give, for example, if you give 50 gray or 60 gray to spinal cord to that patients may fail myelitis. Means a patient may make the patients paralyzed. Okay, so this is why we call in this cost function serial and parallel. Okay, we differentiate these into different organ at risk. So of course, in bladder, it is not a very serial organ, but we will still use serial in these cost functions where these serial organs, why my computer is moving? Okay, where this this serial organ, there is a power law exponent. This value is how we control the maximum dose to give to the organ at risk. For this function, the highest the number, you will push the computer to make very hard for you. Okay, and then this one also I won't explain very details here because this one is all based on Monaco system. So I will need to tell the computer, okay, why this one? Oh, this one I click. Okay, now this for example, this one is my colleague plans. So for this bladder, she put in a serial cost function with the dose 47 gray with the value power law exponent 7. So for this means not very hard or not very soft to push the organ at risk DBH. Okay, this one is very depending on your experience on how to play around this value. Okay, then also we will tell, okay, the next cost function is overdose DBH. Okay, what is overdose DBH? Means I tell the computer my maximum volume that this bladder can receive 55 gram is 4.8% only, because for CA prostate, there is a protocol we call chip protocol. There is set of DVH set for bladder and rectum where volume 55 gray. No, sorry. There is not more than 5% can get more than 55 gray. Okay. For which means V55 is V55 less than 5%. Okay. So I will need to tell the computer I don't want more than 5. Now we set 4.8% to get more than 55 gray. Okay. Same to OAR rectum. For this, my colleague set in parallel functions. Okay. Parallel function. So that's why I said is any function, cost function you can put in as long as you understand how does these functions play. So you can either set serial or parallel, everything. Okay. So now for this patient, he will set mean organs damage 59%, not more than 24.6 gray. How do we key in all this value is based on the DVH given. Later I can show you later after I explain this one. So for same things, she also use overdose DVH to limit the dose 4.5%, not more than 55 gray. Okay. For this PTV plus, you will just ignore because this one is based on our experience. How do we want to confirm the those distributions? Okay. Then after we key in all this, then we will click optimize. We will click optimize to let the computer start optimize a good plan for you. So after everything done, and then you see, Miss, now I already set everything to computer. Now you work for me. This is what I want. Okay, that's why we call inverse planning. So after the computer done the plan, okay, let me turn on the dose. I want 55 gray. Yeah. Wait, I have to reopen the plan first. Okay, for example, the her plan. Okay, for this plan, the orange color is 55 gray. The yellow color is 52.25 gray, where it is a 95% coverage. Okay, for this plan, the yellow color is covered well in the PTV1. Okay, PTV1 or everything get 52.25 gray. Okay, this plan. Then we are not looking at this dose distribution only. We are also looking at the DVH. So the DVH, we will set in the criteria. Oh yeah, this plan, I can't see the. So for this Monaco system, we can set in a template for all the DVH. Means every time when there is prostate plan, we will straight away apply this template where we already set in all the DVH. So for every time we no need to re-key in the cost function and the DVH criteria. So for this chip protocol for 60 gray in 20 fractions, the PTV set is minimum 50% receive 55 gray. Okay. at least 95% receive 52.25 gray dose. Means just now what I mentioned is this yellow color. Okay. So all the PTV receive at least 52.25 gray with the volume at least 95%. Okay. So okay, let's go to the bladder. So bladder and rectum, there is a lot criteria where we need to meet. So there is V55 gray, not more than 5%. V57 gray, not more than 5%. There is okay, this two is not more than 50% of the bladder volume receive 37.4 gray. Okay, for this plan, where because this one we already set in the criteria, once the computer generate the plan for you, we can straight away see if there is a green tick here, means all the criteria achieved. So where else you will see this red color false icon here, means the computer can't give what do you want. See, for this rectum, we want less than 15% get less than 52.25 gray. Okay, but with the MMRT constraint we set just now, the computer gives us the plan with 29% receive 52.25 grade, where is the DVH is fair. This plan I cannot accept. Okay, so all these red means the plan cannot pass, cannot be passed. Okay, so now what should I do for this plan? Okay, I will need to retell the computer by changing all this IMRT constraint. This one is really depends on your experience on how do we edit this parameter. Okay, but this is my colleague plan, so I will just leave it so she can do it later. I don't want to override the plan. So you will just edit all these parameter until the computer give you all green tick. Then only as a physicist, we will show this plan to the doctor. Say, okay, doctor, this is the plan we have done. You can review the plan and approve it. Okay. So there is situations where even though the DVH is set in, but we can't achieve. For example, in these patients, okay, if the rectum value or the bladder volume is small, we won't achieve all this. Okay, under this kind of situations, we will tell the doctors, either doctor need to accept all these fair dosimetry criteria, or we will need to think on how can we do on these patients. Okay, for example, I have another patient where is a very old uncle with CA prostate 2. This old uncle, the bladder volume after he drink 4 cups of water is the same for these patients, but after it is 55 minutes, the bladder volume is still very small. Okay, let me open that case for you. So I can tell you here what we can do. So you can see we actually plan a scan from 20 minutes, 40 minutes, and 50 minutes, but still the volume is can't achieve. So this is the Yeah. Because I'm remoting, so the internet line will be a bit late. So for this patient, this is the one. Okay. This is the bladder volume after 50 minutes. Compare with the patient just now. This plan is we can't achieve everything after we plan. When we see the bladder volume during the CT simulation time, we definitely we know already this patient plan is very difficult and can't be achieved. So based on because this is based on our experience, we straight away tell the doctor, the patient bladder volume cannot, the TPS share is a fair. So we will try, you see here, all this is a false icon. So all fair with this kind of bladder volume. The only things doctor can do is, but because at the same time, we also need to treat the patient with a 55 gray dose to the PTV. So that's why either doctor accept the OAR dose can't achieve, or she reduce the dose to the planning target volume. So in this, doctor need to balance up. She want the PTV dose coverage or OAR dose coverage. So doctor need to decide on this one, not physicist, yeah. So doctor need to decide on this. So with this, after this is the first day simulation day. So on the simulation day as well, we actually know already this patient, this uncle, after 50 minutes waiting, the bladder volume can be achieved. So we actually ask the patients wait until 60 minutes. So this is what after 60 minutes. Need to close this one. Okay, this is the 60 minute and then this is the 50 minute. Still the bladder volume is not really big. Then as a physicist, I adopt the new bladder volume into this plan to see whether the 60 minutes volume is the DBH pass or not. So then after I compare everything, this bladder new is the 60 minutes bladder volume. Yeah, this one I will save. So this. Okay. So okay, Now this bladder new. Bladder new is after 60 minutes volume. As you can see here, it's still fair, but for this V55 less than 5% is actually original plan 36% receive more than 55 grade, but the 60 minutes plan 20.8% only receive more than 55 grade. So means by using a 60 minutes protocol, we can reduce the toxicity to the bladder, even though the DVH set is not achieved the tolerance. So at this point, we have tell doctors this is the situations. Doctors can either accept it or how. So we will monitor patients day to day to see how is the patient's condition. Is there any severe side effects or not? So for this kind of situations, there's a as a physicist, you need to judge on how can you improve the plan, or what can you tell the doctors, or how is the patient situations. Unlike just now, the first case I show you, this is a very big bladder volume. So for definitely the bladder volume DVH is passed. So as a physicist, you need to judge. So everything is based on your experience on how to create a good plan where all the DVH met. So this is how we create a plan, a remap plan with all the cost functions. You can play everything you key in here. The computer will give what do you want. So it's really based on the experience on planning. So even though as a fresh grad, you need to understand what is the cost functions works. Then only you can generate a plan. Normally, if you are new physicist into a hospital settings, normally after 6 months, or it depends individual pickups capability. So normally after 6 months, I will teach my junior on how to generate a remap plan from simple to difficult. So normally we will give either a brain case or prostate plan. This one is very simple for them to learn everything until after they understand all these cost functions, and they practice on how to create all the plan until as a senior we confirm that he or she able to generate a good plan. Then only we'll go to the next step where there's a lot of OAR. It's for example hair and neck cases. So we wouldn't expect you as a fresh graduate you will know all this. So this is what as a senior we need to teach the junior. But of course, as a junior, you will need to self-initiate to learn all these things. Don't wait until your junior teach. Don't wait until your senior asks you to learn, then only you go and learn. So you can pre-read all this, because all this there is a teaching material at every hospital. So you can pre-read all these functions first. So before I go to another 4D technique, that one I just want to show you the current technology. Before I go to that, is there any other questions? Is there any questions? If there is no question, then I will proceed to the next, because we have another 30 minutes. Okay. Apart from this, prostate plan is a very simple plan. So now actually we go to, I want to show you this one. This is a Zielang, oh sorry, teaching material be available for students. Can the teaching material, which teaching materials do you mean? If you are saying the Monaco cost functions teaching material. This one actually you can download from website. I think they did dump into the website for the Monaco, but I don't encourage you because you don't know where are you working later. If you are very hardworking student, you can learn all this planning system in advance. Means you can learn about Monaco and the Eclipse. There is an Eclipse treatment planning system. There is research planning systems. Okay, all this you can learn in advance as long as you can understand what their meanings. So there's another question is, if there is city with contrast, planning will be done on contrast city or non-contrast city. It depends. If the contrast city scan is done in imaging department, we won't use that city image for our planning because they are in imaging, their position is not like us. They didn't fix any position that can be reproduced for the treatment. So if the imaging fields is from if the contrast imaging is from contrast CT scan from imaging, we won't use that set data for planning purposes. While if the contrast is injected during our CT simulations planning, we will directly use that CT image for our planning purposes. There is an example here. I have a head and neck cases where we inject contrast. So normally, doctor ask for contrast injection is just they want to differentiate all the tumor and the blood vessels. So for example, okay, as you can see here, all these are bright white color. I mean this one. These small round white color things actually is our blood vessel. As you can see, this stream is all the blood vessel. So doctor will differentiate this is the blood vessel or that one is the lymph node. So this is the purposes they want to inject the contrast. Okay, you can see here there is a small for this patient. This patient can't really see the this one. So if without contrast, this blood vessel, you can't differentiate this is a blood vessel or this is a lymph node. You can see this small dot here. Actually, this is a lymph node where a swollen lymph nodes where we need to treat this as a target. So if without contrast, doctor may a little bit difficult to differentiate which one is which. So the purposes of the contrast is differentiate blood vessel and lymph nodes. Okay. Then we go back to, okay, any others questions? Then else I share with you, this is the 4D gating CT scan. So not many center have this, but this is the new era of radiotherapy treatment delivery. Actually, in overseas, they have used this technique a few years back, But in Malaysia, we are just recently, maybe 1 or 2 years back, we are start using these techniques. Okay. So for this CL lung patient, you can really see a small lung tumors over here. If there is only one small tumor in this patient. So as you know, lung is a motion organs. So when we breathe in or breathe out, our lung will expand or will expand or will expand. Okay. So how can we encounter these situations where the lung tumor is actually moving during the treatment? It's not a solid, stable tumor. This is a movable tumor. So how can you make sure when we deliver the treatment to this PTV is at the correct location? Because when you can try to breathe in and out now, you will see your chest is rise. Okay, so how can we make sure we are treating the same thing, the correct things? There's few technique you can use. Okay, in our center, we will perform a 4D CT scan where during the scan we will track the inhale and the exhale patterns. It means so when the scan, our breathing will be like this. Okay, breathing will be like this. Okay, the CT scan will scan all these. So after we scan, the CT scan will automatically split one cycle of this. Sorry, that is this one cycle or this inhale and exhale into 10 phases. 10 phase. You split maybe let's say 1, 2, 3, until 10 into 10 CT scan, 10 images. Okay. So after these 10 images, we will need to import all these 10 into our planning system. Then the Monaco system will generate average on this, because all these 10, it track the tumor movement during inhale or exhale. So after we import all this, we Monaco will generate MIP 10, means the average movement. So for here, we will tell the doctor, this tumor we can see here. Okay, I play. This is the average CT images from inhale to exhale for one cycle. So you can see this tumor. So I will play. So you will see the lung movement of these patients, and also the tumor movement. So from this technique, doctor now can decide how much margin she want to put in for these patients. Okay, this is method 1. So after doctor contouring, we will this patient. Sorry, and this one. Okay. Okay, this one. Okay, this is what have doctor contour according the brown color is the GTV. Doctor contour according to the motion of the tumor. Okay, then only she adopt another 2 mm PTV margin to encounter there is planning reproducibility discrepancy. Okay, this is what doctor do for these patients. Okay, then physicists will create a plan according to it's the same. Physicists will create a plan according to what doctor control. Then when we send the treatment plan to the radiographer, how can they make sure the lung tumor movement is same as what we see now? How can they share? Okay, there is few methods. First, because of this patient, doctors is already calculating the margin of the tumor motion. So means that she have already encountered all this movement margin. So radiographer can straight away treat these patients with free breathing. Means just a normal patient, and then they just do the Cbct scan, make sure the position is correct, then they will just treat the patients. This is method 1. So this another method 2. Actually, for these patients, doctors aims to do a DIBH technique, where DIBH is called deep inspiration breath hold techniques, where we take a deep breath, then we hold our breath. So when we hold our breath, our lung won't have any motions. So it will fix the tumor positions at that holding period. Means where you breathe just now is like this. Okay, when we hold our breath, it will be like this. Okay, this is the area where we hold our breath. This is the time frame where our lung don't have any motions. Okay, at this time frame, we can 100% sure the treatment delivery to that tumor locations is exactly the same. Okay, without any lung motions. Okay, but after we try to train this patient to hold the breath for at least 20 seconds, and there is a criteria to set how deep you need to breathe in. This patient is a 60 years old patient. Unfortunately, she can't hold her breath until the target reset. So means we actually want patient to breathe in until these boxes. The breathe means example for this, we actually set this. We actually set this target, but she can only breathe in at this level. Yeah, at this level. Okay, so it can do a proper DIBH technique for this patient can perform a good DIBH technique. So at the end, we drop this DIBH technique for her. So we will just practice using method 1. Okay, method 2 she can't. So there is a method 3. During the treatment, we can perform a 4D Cbct, means a cone beam imaging. It's a 4D where when patient move in, on the same time, there is a CT scan perform, a cone beam CT performed during the treatment. So from this, we can track the patient's lung movement. If during the treatment, the radiographer see the tumor is already out from the PTV controlling, they will immediately pause the treatment. Okay, then ask patient to relax, then only we will again resume for the treatment. There is also automatic and manual. Automatic means you will tell the machine automatic beam off when the tumor target is out of tolerance, or you need to do manually. It means the radiographer beam on or pause the treatment manually. So these patients will only start her treatment Tuesday. So that's why I can't show you the 4D Cbct here, because previously we have another patient, but I forgot which is the patient, so I didn't grab the patient data to show you over here. So if you have chance to visit to other hospital where they have this 4D CT technique, it is a very good knowledge for you all. And then there's also now currently all the treatment center we use IGRT, means image guided radiation therapy. This is what we perform is you do a Cbct to see your position is correct or not, then only you deliver the beam to the patients. Then now with this 4D gating, we have also another things called SGRT, surface gated radiation therapy. Means the device will track patient's body surface. If the body move a little bit from what we have captured first time, the machine will automatically pause the treatment until patient back to the capture positions. That is what we call SGRT. Okay. This is a little bit deep for you. There's a lot online teaching courses. Actually, we are also learning from these online teaching courses to learn how can we adopt all this to our patients. So if you are very hardworking, you can go to the website called there's AFOMP, AFOMP. This website that is always online teaching, and there is another called where I don't remember what is the name. But when you scroll this, then you pop up a lot of these teachings, online teachings, webinar. There is free and pay teaching course. So of course, normally we will go for the free one, and then they are very good. Also, they will give us attendance certificates. So until here, is there any questions for me? Any questions? No questions. Is it very deep for you all? Oh, there is just now I mentioned the online teaching one. You can go to Radio Surgery Society, and then let me see. Once you subscribe one of them, then always they will send you email. There is a new things for you. RK Educate. Let me open it. It's not this one. I just cleaned my email yesterday, so I can't see what is the online teaching course. But you can search it out lah. It may very deep for you, but it's a good thing to learn. And then recently there is this one, SJ. This one. SJ. There's a new India Society. ELP. CMPCR. CMPCR. So you can go to this scmpcr.org. There's a lot e-learning things here, and then some this one, if not mistaken, there's some small amount money to pay, but it's a very cheap money. But as a last I'm joining is only 80 ringgit, one RM 80 for the whole course. It's a very good, as although there is a Indian lecture in Indian professor to teach, so you need to listen carefully because of their slang. There is also, of course, there is also overseas like US or Australia lecturer to teach, a speaker to teach. But for this, you can go this. This is a very good group that will teach. So you see, I think the recent one, the latest one is this interventional. This one, computer tomography and intervention radio. Of course, this one is more to the imaging sites. So you can follow this one. Then they will always give you. They will let you know what is their courses. Okay. Do you have anything else to for questions?
Any question? Is everything clear? Mister, can you provide your email just in case they wanted to ask something, so they know how to reach you?
Okay, I type in the chat box. Go to my personal email. Don't go to my working email.
So any question? No question? Okay, this is just a notice. Since there is no question, can we just have like a photo session before we end this session? So while waiting for you to get ready, I just want to congratulate all of you. So Alhamdulillah, last week, all of them has finished their Viva, submitted their final copy of thesis. So they're basically, I'm not sure when is the results coming out. So probably this week or somewhere next week. But they basically, most of them has completed the MSc. So they are ready to work now. So congratulations to all of you. So we are waiting for you to on your video so that we can take a photo. So this probably will be our last time session together, since you'll be graduating already. So I believe that most of them also already went back to their hometown, clear their hostels.
Oh,
Yeah.
so how many of your students have get the medical physicist position in hospital?
This year, I'm like with them. I don't think any of us.
Not yet.
Not yet, yeah, because I just finished. I think
There's more and more center
But
coming up.
few has informed me that they have gotten like an interview, but not yet getting the position.
We hope the government can implement there is physicists in imaging department. Then they will create more vacancy.
Well, at the moment, there are none.
They
I
implement
only heard about this in government, right? But not in private sector.
Yeah.
Yeah.
They said they want to implement in private too, but until now they haven't implement it. It's many years they discuss this one.
So basically, those from, I mean, for diagnostic, then who's actually are going to, I mean, handle them? So
Nobody
you
will
are
do.
essentially nobody. So you only have a radiographer then.
Yes.
So
Because
those in charge in radiotherapy have to
in private
check test.
setting, no one want to do extra work.
Yeah.
We are very busy in the radiotherapy. You still want me to cover imaging for what? So if you want, you give me another physicist, like that.
Yeah. Then how about the radiation protection part of the
We will
radiology?
combine imaging. The whole hospital will combine together. Then, as example, in my hospital, my radiologist is one of the RPO, and then me as another RPO. But you know, radiologists they won't work. So basically, I'm the one doing everything.
Understood. It's always like that. No one else want to turn on the video? We are waiting. I'm not sure if more is coming. Probably they are at home and difficult to on the video. Okay.
Just screenshot their name then.
Yeah. Okay. Ready? So I'm going to screenshot the photos now. Ready? 1, 2, 3. Okay. Done. Thank you so much, Miss Teo, for your time. So I know that you are very busy. So hopefully, I'm not sure about next year, but hopefully we can actually still continue with the program, because I'm going for sabbatical next year. So probably Dr. Yasmin will have to arrange another session for the student next year.
I have tried to develop a teaching program in my hospital setting so we can enroll in the physicist, the student. I have to set up the program in the hospital first, then only my HR can accept.
That will be better actually for us because we are also
because
looking
we
for
have a
at least
lot of
a
audits,
clinical
so
setting.
they can't accept it.
Okay. All right then. Thank you so much,
Thank you,
Ms. Teo,
everyone.
and everyone who has attended. So congratulations for finishing up your study. All the best for your future. Hopefully you can be a medical physicist. See you again, inshallah. Bye.
Thank you, Dika.
Tomorrow.